Hello everyone. I hope that you all are doing fine. And so we are meeting after a few days. All right. So we will start with this topic today, which we left here, like the indications for analgesics for acute dental pain. And hopefully, I will try to complete this book, like TT, as soon as possible so that we can cover other topics as well before your exam. Okay, so indications for analgesics for acute dental pain. Analgesics modify the sensation of pain but do not address its cause. So, what you need to do to address the cause of pain is the active dental treatment. Therefore, for acute dental pain, analgesics should only be used as an adjunct to dental treatment in the following circumstances. So, as we read in this table here, that we do not need to prescribe analgesics in every case. Like, for example, in reversible pulpitis, we are not prescribing the patient any analgesics. Okay, so that's the reason there should be some certain circumstances where we need to prescribe them as an adjunct to dental treatment. So first is always dental treatment. When the patient's pain cannot be eliminated or adequately controlled by dental treatment and other required drugs. For example, antibiotic therapy for spreading infection. Okay, in that case, we need to prescribe the patient painkiller as well, because the pain would be so severe, the dental treatment would not help the best. Then, following surgical procedures that cause postoperative pain, some surgical procedures, like for example, extraction. So, after the numbing goes away, the patient would be in pain. So, that postoperative pain is normal, but for them to be a more bearable, we need to prescribe them certain painkillers. When a patient has presented to a medical practitioner and is unable to see a dentist promptly, so interim analgesics, as we read in this table, that the medical practitioner would prescribe the patient, should be offered for certain indications, and the patient should be reminded that dental treatment is necessary to treat the cause of pain. Then the analgesic regimes in this topic are only suitable for nociceptive pain. This, like as we read, the nociceptive pain is the pain that is acute dental pain. Okay, and generally the patient comes with this feature only. So these analgesics are best suitable for nociceptive pain. For neuropathic and nociplastic pain, further investigations and other management approaches are required. All right. So how you will make a choice for analgesics for acute dental pain? Factors that influence the choice: first, you need to consider if the patient's pain is mild, moderate, or severe. Pain severity determines the most suitable analgesic regime. When assessing pain severity, consider both patient reported pain severity and the expected pain severity based on the cause of for pain. So you need to consider is whether this diagnosis can cause this much severe pain that patient is telling you, or is it expected pain severity or not. So you need to consider it first. What you need to find out is the pain severity. Then consider potential adverse effects and contraindications or precautions to analgesics use. It means that you need to find patient's medical history, and you need to consider if this patient is able to take this particular drug or not. Then, can the patient take medications orally? Then you need to choose the route for the patient, like oral route or IV or IM. Like oral administration is generally the preferred way. If this is not possible, for example, in patient having difficulty swallowing or GIT absorption is reduced, then you need to consider suppositories or other type like injections. Although NSAIDs are the preferred drugs because they have anti-inflammatory action, and their adverse effect profile limits their use in some patients, because we read in uh, like earlier topics that there are certain cases where we cannot prescribe NSAIDs. For example, if the patient has asthma, which is exacerbated by the NSAID, or the patient has peptic ulcer or any kidney issues, or pregnant women. So in those cases, we cannot prescribe them, but they are the best drug for pain relief. Before prescribing an NSAID for a patient, determine whether NSAID use is appropriate based on their comorbidities and risk factors. If NSAID is appropriate, then ibuprofen would be the best one because it has good efficacy with limited toxicity and it has widespread experience with its use. So if NSAID is okay to give in that patient, then prescribe them ibuprofen other than other like naproxen and celecoxib. Then paracetamol can be combined with an NSAID or used alone in patients who cannot tolerate NSAIDs. Then opioids can be used for acute nociceptive dental pain in adults when non-opioid analgesics means ibuprofen and paracetamol, and the non-pharmacological measures, which means dental treatment. Sorry. So for example, you did the treatment, dental treatment for the patient, and you have even prescribed him NSAIDs and paracetamol, and still the patient comes back to you and says that this is not effective for my pain. Then you can prescribe him the opiates, okay, and oxycodone is the preferred, do not use codeine. Then combining analgesics from different classes can result in enhanced pain management or synergistic analgesia. For example, combining ibuprofen and paracetamol provides greater pain relief than either drug alone. So for mild to moderate pain in adult, what you need to give is non-opioid analgesic, that is the NSAIDs and paracetamol. They should be prescribed, and you should tell your patient and that take them regularly, like take them for 5 days. For ibuprofen, it is 6 to 8 hourly, and for paracetamol, it's 4 to 6 hourly. Do not take as required, just take them regularly as a dose. Okay, so the dose you need to remember this, just write on a piece of paper and just review it again and again, or just try to remember it, whatever way is good for you. Okay, and then avoid fixed dose combination, because sooner the patient's pain is getting better, we can stop the ibuprofen and patient can only take the paracetamol, because you know that the paracetamol has the better, safer profile as compared to NSAIDs. Okay, so as the tissue heals, you can ask your patient to stop ibuprofen. Then, if a COX-2 selective NSAID is preferred, like we read in previous topic, that in certain cases, for example, if in case of any heart problem, if we need to prescribe the patient's COX-2 selective NSAID, that is the celecoxib, then you can prescribe this dose. Okay, which is the 100 milligram orally 2 times a day for no more than 5 days without review. You need to tell your patient, if you are prescribing any NSA, that you do not take it more than 5 days, and if you still require, then come back for a review and we will find out what's actually happening, because generally the pain should gets better within 5 days. As the tissue heals, then stop celecoxib and use paracetamol alone. If NSAIDs are completely contraindicated, then use only paracetamol 4 to 6 hourly for the shortest duration possible. If analgesics are used after a surgical procedure that causes post-operative pain, inform the patient of the usual course of pain, which is like pain is worst 48 to 72 hours after the surgery, and then it will goes to improve. Then it will improve, right? So because even if we did the extraction, so due to those soft tissue manipulation, the patient would be in pain, and it would be worst between 48 to 72 hours, and then it would improve. Advise the patient to return to the dentist for review if pain persists. Then for severe acute dental pain, what you need to consider is, for factors that affect the choice, you need to consider the page 137, which is these factors, which you need to find out the severity of the pain, the analgesics used, like the medical history and the route. Okay, after that, the NSAIDs and paracetamol should be taken regularly, so it is the same thing. So for the severe acute dental pain, you need to prescribe the patient three drug regime, which is the ibuprofen and or celecoxib. If in certain scenario you cannot give the patient ibuprofen, then you need to prescribe celecoxib plus paracetamol plus oxycodone. But for the oxycodone, the prescription should be only for 3 days, and use a lower dose in elderly or frail patients because they are particularly vulnerable to adverse effects, because we read that these opioids have very severe adverse effects and they do cause a lot of drug interaction, so be more cautious with them. In patients who cannot use NSAIDs, use paracetamol plus oxycodone. For example, if the patient has any of those things like hypertension, or then you can prescribe, in case of severe pain, you can prescribe them paracetamol plus oxycodone. Always consider the benefit and the harm profile before prescribing anything, and then prescribe the lowest effective dose and advise patient to take a dose only when necessary. Okay, so here we read that NSAID and paracetamol should be taken regularly, but uh, the for the opiates it is like you should only take the dose only when necessary. You do not need to take it regularly, because we are trying to avoid the use of oxycodone or opiates as much as we can, and ensure the patient understand the intended duration of opioid use and when to stop taking the opioid or return for review, which is the 3 days. Then if a pain persists for longer than expected, this is a particular importance because long term opioid use starts with the use often starts with the use of opioid to treat acute pain. Okay, and as the tissue heals and the patient require less analgesia, then advise the patient to stop the dose stepwise, which is first stop the oxycodone, then stop ibuprofen or celecoxib, and lastly stop the paracetamol. Then for patients currently taking opiates for another indications, consult their medical practitioner to determine an appropriate analgesic regime. If the patient is already taking opiate for any other problem or any other indication, then you need to ask their GP that what would be the best pain analgesic regime for them. Specialist pain management advice may be required if the patient is opioid dependent. If the opioid have not been required in hospital or pain can be successfully managed with non-opioid analgesia, do not prescribe opioid on discharge. Like here, they are just trying to make you understand that avoid opioid as much as you can, because they do have very severe side effects for the patient, and according to the benefit harm profile, they do have more harms. Do not use modified release opiates for acute dental pain. Then, administering local anesthesia by infiltration or regional block is an alternative or additional strategy for the management of severe acute dental pain, provided the clinician is competent in this method. So, if the patient has come to you and he is in severe pain, you can try to give him the local anesthetic by infiltration or by block. That would help him with the pain, and it is an additional strategy. Then, if analgesics are used after a surgical procedure that causes postoperative pain, then you need to inform the patient that the usual course of pain is, which the pain would be worst 48 to 72 hours after the surgery, and then it would improve. But if the pain still persists, then return for review. Then analgesic regime for acute dental pain in children. So for the children, do not use aspirin in people younger than 16 years because of the risk of Rayleigh syndrome, and do not use opiates for acute dental pain in children outside the specialist setting. So you are not prescribing any aspirin to the patient, to the kid, or neither do you need to prescribe any opiates. So these two drugs are just crossed. Then for acute dental pain in children 3 months or older, you can use ibuprofen or paracetamol. Ibuprofen and paracetamol can be combined for enhanced pain management, and give dose regularly rather than as required. What should be the ibuprofen dose, which is 5 to 10 milligram per kg. Okay, up to 400 milligram orally 3 times daily at 6 to 8 hourly interval, and no more than 3 days. For the adults, we was doing here 5 days. For the kids, it's only 3 days. Okay, and the dose is also calculated according to their weight, which is 5 to 10 mg, and for the paracetamol it's 15 mg. So just add these one and then you will remember better. Okay, so 15 milligram per kg up to 1000 milligram orally 4 times daily. Okay, and this was 3 times daily and 4 to 6 hourly interval, and for shortest duration possible. For children who are not obese, then you can take their actual body weight to compare the dose that you need to give to the kid. But for the kid who are obese, then you need to check their ideal weight, because otherwise if you calculate according to their exact weight, then the dose could go on high percentile. Okay, then firstly they do consider the weight, and secondly if the weight is high or something, then they also consider the age based doses as well. So this is the table which is given here, that they have calculated the dose according to the kg, and this is not very important according to the exam point of view, but just you need to understand these values. All right, then temporomandibular disorders. This is a temporomandibular disorder. It is very important topic, and there would be at least one scenario in exam from this topic. There would be one or could be two. Okay, so I would do this topic from tomorrow. All right, thank you so much, guys, for watching my video, and yeah, thank you so much.